Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
Hello, everybody, and welcome to this debate, the great debate on is seizure freedom always achievable in focal epilepsy? I will be the moderator for the debate tonight. I'm Jacqueline French. I'm a professor of neurology at NYU Comprehensive Epilepsy Center in New York, and I'm going to allow my colleagues here to introduce themselves.
All right. Hello, everybody. I am Patrick Kwan. I'm a professor of neurology at Monash University in Melbourne, Australia.
Hello, everyone. My name is Eugen Trinke, and I'm professor for neurology at the Paracelsus Medical University in Salzburg, Austria.
And we will let these gentlemen debate in a couple of minutes. But first, I am going to remind you of a couple of facts about epilepsy. So epilepsy affects about 50 million people worldwide, and there are 5 million new cases every year. And while we can get 2/3 of those people seizure-free relatively easily with various treatments, mostly medication, we know that 1/3 of those individuals will not be seizure-free and will require some sort of further evaluation and possibly surgery, other therapies, and continued drug treatment. Let me remind you about the definition of drug-resistant epilepsy. This is the definition that was determined by the International League Against Epilepsy, and it is the failure of adequate trials of 2 tolerated, appropriately chosen, and used anti-epileptic drug schedules, we would now say anti-seizure drug, whether as single monotherapies or in combination, to achieve sustained seizure freedom. And if somebody has failed 2 anti-seizure medicines, the likelihood of them becoming seizure-free with subsequent trials of medication is progressively going lower and lower and lower. But there was an intentional reason to use the word drug-resistant rather than the older word refractory. And that reason is that there is good evidence that a proportion of these people who are treatment-resistant or drug-resistant will gain seizure freedom, and we will discuss this as we go along with our debate tonight. And we do know that so-called drug resistance is a dynamic state. There have been several studies, this is one of them, that took people who were having at least 1 seizure a month and had reached that definition of treatment resistance from the International League Against Epilepsy, meaning that they had failed 2 anti-seizure medicines. And yet, in this study, 12% of them did attain seizure freedom over the course of 3 years. And that was when there weren't as many available anti-seizure medicines as there even are now. And we do have some newer medications that are quite efficacious. So does this mean that you look at the slope of this line, and I think that a thoughtful person might say, well, then if that is what happens over 3 years, what happens over 4 years and 5 years and 10 years? Does it mean that if you waited long enough, every one of those treatment-resistant people would eventually become seizure-free? And with what effort and how hard should we try? And that is some of the things that we will be discussing tonight. So we are going to limit our discussion tonight to focal epilepsy. There are many other types of epilepsy. There is generalized epilepsy. There's epilepsy associated with developmental and epileptic encephalopathy. Why are we limiting it to focal epilepsy? Well, first of all, we only have half an hour here tonight. So in the interest of time, we are limiting it. Secondly, there is a lot of relevant data on this point because focal epilepsy is in fact the most common cause of or type of epilepsy. And also, people with focal epilepsy are candidates for surgical resection, and that's part of the discussion we will be having here tonight. We'll hear cases for and against seizure freedom always being achievable, and we have Patrick, who's going to take the side of yes, seizure freedom is always achievable. And on the other hand, we have Eugen, who will be giving the case for no, we should not be trying to make every single person seizure-free. And after we hear both sides of the debate, of course, we will try to achieve some sort of consensus, which I'm sure we will, and finish with audience question and answer. So, before we start our debate of is seizure freedom always achievable in focal epilepsy, of course, we want to know what you think. And so we are going to ask you to vote. Where do you stand on this question before our faculty start their arguments? And we will ask you again at the end. So the first person to give their side of the argument is Patrick. So Patrick, please take it away and tell us why seizure freedom is always achievable in people with focal epilepsy.
Great. Thank you, Jackie. So my position starts from the point that seizure freedom is always achievable in focal epilepsy. And when you always see the word always, you think that this is a hard position. And this, I'm not trying to get your sympathy on this, but let's get the elephant of the room out of the way. Because just looking at this, you would say, oh, this sounds pretty extreme to say seizure freedom is always achievable in people with focal epilepsy. But I would argue that the opposite is equally, if not more extreme, to say that seizure freedom is never achievable in some people with focal epilepsy. Imagine you explaining this to a patient in your rooms sitting in front of you, that they are never, ever going to achieve seizure freedom. And so I would like to use the next few minutes to convince you, in fact, drug resistance itself is a misnomer or a myth, because there are always now many other reasons for treatment failure, in addition to what Jackie has explained. And this is a phenomenon that has been coined pseudo-resistance, meaning that the resistance or the ongoing seizures the person experiences is not directly related to the efficacy or even tolerability of the medication, but due to other reasons. For example, if the person does not have epilepsy, then obviously anti-seizure medications are not going to help them. And we know there are many mimics for epileptic seizures, and you can just see a few listed on the screen here. And sometimes it can take a lot of time and effort and various investigations, including meeting a patient for a video EEG monitoring to sort out exactly what is the correct diagnosis. And a second reason you can see here on this slide is that the wrong drug has been chosen because, as you heard from Jackie's introduction, that drug resistance, or defining it, depends on the use of appropriate medication for that particular type of epilepsy. And we know that for some types of medications, they can actually exacerbate certain types of seizures. Obviously, there are interactions with other medications as well. And that comes to the third point too, because sometimes just the wrong dose is being used. And all too often, physicians could be relying too much on the so-called therapeutic drug levels. There is no therapeutic drug levels. We have references for us to refer to, but many patients often respond to higher doses, higher levels beyond these levels. So we must individualize and interpret these drug levels and tailor for that particular individual. And last but not least, which I'm going to touch on a little bit more, are lifestyle issues, in particular compliance with medications, because if the medications not being taken, they are not going to work. And you see here two important studies The first one is a study of people who were admitted to the hospitals for breakthrough seizures. And as you can see, nearly 40% of patients were likely not taking enough of their medications because they had a very low drug levels in their bloodstream. And the other study is that of these, about 660 people who were surveyed in this, over 70% said they had missed a dose at least once. And of those people who missed a dose, nearly half of them would experience a seizure. And what's even more alarming, I think, is that less than a third would tell their physician that they have missed a dose. So when you ask the patients whether they have missed a dose, take this, bear this in mind and explaining. And we see an average of 2 doses being missed per month. So how can we improve adherence? In fact, there are a number of ways, and a lot of studies have looked at this and how to improve adherence, definitely providing more education and asking the reasons for adherence. And the purpose here is not to blame the patient as such, obviously, but to really find out what is the reason. Is it because they're experiencing side effects? Is it because the regimen is just too complicated? And often people are just like you and I. We just need a bit of reminding. So often these simple tricks could help to improve adherence and avoid both intentional and unintentional non-adherence to medications. And I know I've taken some time already, but we haven't even touched about other treatments that are not medications. And these include surgery, which can be resective surgery, and just remind us that we don't necessarily need to have to see a lesion for a person to become a candidate for surgery. Even people with so-called MRI negative epilepsy can still be a surgical candidate because we can look at other investigation results. And there are more advanced surgical techniques such as LIT or laser interstitial thermotherapy, which is far less invasive than the traditional resective surgery. And surgical treatment is by far still the most effective treatment for people with drug-resistant epilepsy for their appropriate candidates. There are other therapies such as neuromodulation or dietary therapies, which although may perhaps wouldn't enable the vast majority of people with drug-resistant epilepsy become seizure-free, but a sizable proportion may be rendered seizure-free, even with these sometimes regarded as palliative therapies. So how do we achieve seizure freedom? First of all, as I hope you are convinced by now, do not give up, because we have a lot of options, both medications and non-medications, to help our patients seizure-free. And when a patient is still having seizures despite taking medications, it's not the time to throw our hands in the air and give up. It's to find out really what the problems are, and understanding and talking to the patient patiently, and spending time to understand the problems. And by understanding problems, we can then solve them using many new technologies now available to us.
So, Eugen,
Thank you very much.
We've heard Patrick tell us, never give up, never surrender. And we would like to know your opinion about that.
Well, I have to take another opinion, but I think you were very convincing. Well, never give up, find the problem and solve it. And this is what we should do. I cannot agree more. But even if we do that, not all the patients will be seizure-free at the end, unfortunately. And this is from a long-term study looking up to 25 years of the natural course of patients with focal epilepsy. And you see that about 1/4 is continuously intractable. Intractable, drug resistance, ongoing seizures. And the predictors are quite clear: high baseline seizure frequency, learning disability, and abnormal neurological status. So it's a clinical diagnosis at that time. Even without MRI, these patients could be identified. And those who become seizure-free, they sometimes had a course of drug resistance for many years, and then they entered a period of seizure freedom, and then they had a relapse, and then they had again a period of seizure freedom. And this may lead to your optimism that we can achieve that in every patient or in every individual. Another study from UK showed very similar things, that if you look at it on a long range, not 1 year, 2 years, but 7 years in this study, there are 75% of anti-seizure medication changes leading to less than 50% decrease in seizure frequency. 8% of patients or individuals were seizure-free after a change in anti-seizure medication. And if you look at the individuals at the last follow-up, 19% were seizure-free, but 52% were not seizure-free. 7 years, high-class center, probably with a good adherence and all the measures. And another study which was very influential, which led also to your definition of drug resistance, which you put forward some years ago, is that from Sheila and Nadja, looking at the seizure response in terms of number of failure of anti-seizure medicines. And what you see here, it looks almost like a slope, like a continuous slope with decreasing efficacy after each anti-seizure medicine trial. But what you see between number 2 and number 5, there is quite a good response, but after number 6, it's almost zero. So what they defined is a relative drug-resistant epilepsy, where you find a response, and an absolute drug resistance where you could not reach seizure freedom. And that was after 6 failed anti-seizure medicines. And then it's finally your great achievement that you came with a consensus group with a very useful definition of drug resistance. And it's a dynamic process. You defined all the measures which you need. It should be appropriate dose, it should be the appropriate drug for the syndrome, and of course the patient should be adherent before you classify this patient having a drug-resistant epilepsy. So I think the major achievement is that it is not a label, but it prompts to move forward for diagnosis, for re-evaluating the diagnosis, for re-evaluating the possibility of epilepsy surgery, neurostimulation, or what you also mentioned, dietary measures, ketogenic diet, for instance. But it's not a static process. It's not a label of the patient. It prompts you to do something, which is important. And also from the Glasgow series, which you know very well, more than 1,000 patients, and looking at the medical response after the first, second, third, fourth treatment schedule. Again, you see a decrease in responsiveness with each failed drug, but you can look at this from 2 sides. Either the glass is half full or the glass is half empty. Even those where 4 drugs failed, there is a slight chance for some of them, but for many of them, there is no chance, unfortunately, even with the new anti-seizure medicines. And one of the reasons why it is like that is the complex course of epilepsy as a group, throwing all the different etiologies into the basket. Some patients will have a burst pattern, so-called burst pattern. They will have high seizure frequency and then respond to medication, and some of them may remain in remission, and others have a relapse. And there are others which have no remission from the onset of epilepsy, and it goes through until the end. And this is the unfortunate group where we have to really take all our measures together. And this definition is not based on data, it's based on experience, and it was published 40 years ago by Simon Shorwan. Newer studies show that it is in the etiology which is so important, whether a patient has a drug-resistant epilepsy or a drug-responsive epilepsy. And one thing I want to point out in this graph, malformations of cortical development have a very low chance of being seizure-free, only 16% in this series, but have a very high drug load, and the burden of the drug load is something which is really impairing the quality of life of the patients. These are amenable to epilepsy surgery, but what is the outcome of epilepsy surgery? 38% are completely seizure-free in this seminal study, randomized controlled in temporal lobe epilepsy, very good surgical candidates. And overall, at 2 years, 49% are seizure-free, including medication changes. That means that 51 are not seizure-free. So surgery doesn't cure, and even if it doesn't cure those 51%, those who have memory problems after surgery are the double losers. And the double losers, they have a reduced quality of life. Why is that so? Because when you remove the focus, you should be seizure-free. Epilepsy is, as you know, a network disease. It's so complex that you cannot predict the outcome completely. You may say that many patients will be seizure-free, but some of them are not, and some of them even have a reduced quality of life. If we talk about quality of life, we have to shift from seizure frequency to other measures. The quality of life is not so well correlated with the absolute seizure frequency in the patients, but with the side effects of the drugs we have and with the comorbid depression. And this study has been replicated several times, and it all showed the same outcome. So if I may conclude, relative drug resistance is intermittent and dynamic and not a lifelong sentence. And this is why you say that it can be achieved in all patients. But some patients will never achieve seizure freedom, and these are those with absolute drug resistance and a continuous pattern. Epilepsy surgery is an option, but only for the minority of cases. And beware of the double losers, because quality of life depends not only on seizures, but also on memory, on depression, and many other factors, especially side effects of anti-seizure medicines. This is why you should avoid overtreatment in the view that you have to render the patient seizure-free, and also avoid undertreatment or therapeutic nihilism, which is never good for the patient.
So, two different points of view. I think they're not as different as they seem, but we are now going to, in the next few minutes, try and bring that together and reach some sort of consensus. So the first thing that I heard from both of you were talking about surgery, that we remind everybody that the vast majority of people who become seizure-free actually become seizure-free from medication therapy and not surgery, whether it be devices or resection. Unfortunately, it is the minority who are a candidate for focal resection, and you reminded us of that, Eugen. But having said that, I think we all agree that people should be evaluated to see if they would be a good candidate, because half of people becoming seizure-free, if they're treatment-resistant, is pretty darn good. There are scales out there, such as one of them is the Epilepsy Surgery Grading Scale, that will very easily, based on a few small pieces of data, such as an EEG or an MRI, give the non-epilepsy specialist a good idea of whether somebody is an excellent candidate for epilepsy surgery or not. But it's never a bad idea to refer to an epilepsy center, a treatment-resistant patient, to determine whether epilepsy surgery is a good idea for them. Would you all agree on that?
Absolutely, yes. I think the definition that's referred a number of times for drug-resistant epilepsy is not meant to be a life sentence, but very much as a flag. The flag is up. There's something different about this particular person living with epilepsy, that because the vast majority, as you've said, Jackie, of people with epilepsy, with neurodiagnosed epilepsy, as we and others have shown, is that they will respond to the first or second or sometimes the third medications. That's the vast majority. So for a person not to become seizure-free after 2 medications, then there's something different about this particular person, and that should be evaluated in an epilepsy center.
So one thing that you said, Eugen, was that, well, first of all, the data that you provided was on drug therapy. So it falls off after the first, second, third, fourth, and you kind of made a statement, it was quite provocative, that 5 and 6 never works. Now, I would ask both of you, from your own personal experience, have you seen people with drug number 5, drug number 6, drug number 10 happen to be the key to that individual's lock? Suddenly that lock opens and they're seizure-free, and that is an enduring seizure freedom.
Well, the answer is yes. Yes, these are patients which respond to drugs, mainly newer drugs which are now on the market. And it's very interesting because this is against what you think it is. It is not constantly going down. There are changes in these patients, probably which we don't understand. Then you give a new drug and suddenly the patient is seizure-free. The question is for how long? And the question is whether there will be a relapse, but you can achieve remission. And this is so important for 1, 2, or even more years.
And I think we've all seen people who had a lasting remission, particularly with the newer drugs, which brings me to another question, which is, we are seeing a new age in anti-seizure medicines, maybe not same old, same old. So I have to ask you guys whether maybe your positions will reverse a little bit in another decade.
Yes, yeah.
Well, I doubt, but no. I think what we now have is we have a different drug response. We have a different armamentarium, especially highly efficacious new anti-seizure medicines, which is very clear. They are unfortunately not available everywhere, and this is one big problem when you think globally. But the number of patients who are going to be seizure-free will increase. And
but
I'm convinced of that.
You're saying probably not to 100%.
Not to 100%. Correct.
So I'll maintain my glass half full mentality.
And
but
say that it is going to get to 100%.
That's, I think, with a lot of effort, obviously. I mean, I think I agree that a lot of data you've shown, particularly Glasgow data, they included what we call now the second generation anti-seizure medications, and did not include the more recent medications that have been approved in the last perhaps the 5-10 years of or so duration. So it would be very, very interesting to look at, with the introduction of these third generation medications, whether they have shifted that the curves or the pie chart of the proportion of patients seizure-free.
Yeah, I mean, that for HIV/AIDS, it didn't necessarily, we didn't have one huge win drug. It was eventually the combination of multiple drugs and eventually getting to the high remission rates that we see.
Yeah. Well, I think in practice, in practical terms, when we manage patients, it's all about relative. What are the options? Yes, with medications we try, and as Eugen, you've said, it could be there's a relapse remitting. We don't know how long the seizure duration will last. So if someone is a clear surgical candidate, then surgery would be the obvious choice in this scenario. So, but when someone is not such a great surgical candidate, then you pursue harder on medication. So it's always I think a pros and cons you weigh up.
I think there are 2 trigger points which are extremely important. One is when a patient fulfills the definition of drug resistance, which you put very clear forward to drugs, and then you have to rethink. That's a trigger point for referral to a specialized center, for re-evaluation of the diagnosis, and for pre-surgical evaluation. These scores help to identify the good candidates for surgery. But what you do in a comprehensive care center is not only saying, well, surgery, no, you do other things too. You do the whole lifestyle modification, you test new anti-seizure medicines, you modify the drug treatment, and you improve overall the quality of care. And there are data from centers, comprehensive care centers in Canada. They show that over the long run, the exposure to a specialized center reduces the mortality significant. It reduces mortality significant, and that's probably the hardest outcome measure what we have. So referral makes a difference because of these reasons, and the trigger points have already been mentioned.
So you talked about referral to an epilepsy specialist center, which is not available for everyone, and certainly not available throughout the world. It's the ideal, right? So can you give some advice to neurologists who are treating epilepsy about how they can achieve the best seizure freedom that they are able to achieve?
Yeah, I think in a very practical way, maybe you can have a few drugs up your sleeve, and that you individualize for that particular person in that seeing you for the first time, and know a number of drugs really well, because there are now, as you probably know, over 25 or even 30 medications approved to treat epilepsy. I think I've lost count. None of us is going to be able to know every single one of these medications, back to front to back. But in reality, most of the time, for focal epilepsy, we have usually several between, I would say, 5, 7-ish medications that you use for most people, and then understand those really well and use them based on your own experience and talking to your colleagues as well. But I think once 2 medications have not been effective, then really that is the time to refer. And I really like what Eugen stressed is earlier on, seizures is only the tip of the iceberg. There's so much underneath. And I think part of the reasons perhaps why people, after they've been evaluated in epilepsy special centers, is because all those underneath what we can see and underneath in the depth of the waters are being tackled. And that's where the benefits come from, and not just looking at the number of seizures.
I absolutely agree with you. So you have to know a few of those drugs, let's say 5, something like that, and you have to know the side effects, the pharmacokinetics, and the spectrum of action. Not all drugs act against all seizure types. Some of them act only against focal seizure types, and if you misinterpret an epilepsy as focal epilepsy and it is an idiopathic generalized epilepsy, you can aggravate seizures, and that's one of the problems with the older drugs, carbamazepine, phenytoin, etc., but also with some of the newer drugs which act on the sodium channel. They can really aggravate generalized seizure types. So you have to know whether this is truly a focal epilepsy. MRI is needed, and neurological examination should also be done in the patients because, as I mentioned previously, simple neurological examination tells you whether there's a focal pathology in the brain, even without MRI, and we were talking about resources. So that's, I think, one of the important things. And then when so many newer drugs come on the market, it's probably also that you have to be slowly acquainting to these drugs and select the next generation of anti-seizure medicines because you won't start a newly diagnosed focal epilepsy with phenytoin anymore because of the side effect, because of the chronic toxicity.
And speaking of newly diagnosed, we know that the most commonly, I think around the world now, the most commonly used medication in newly diagnosed patients is levetiracetam. And there is a reason why the definition of treatment resistance is failure of 2 anti-seizure medicines. There are several studies now that suggest that people can really not respond to the first medication, let's say levetiracetam, and then respond 100%. And talk about the people with very frequent seizures. Even those patients may respond 100% to a second drug, even if they've failed the first one.
Yes, and I want to pick you up on that because that's exactly what happened to one of my patients. He's a relatively young man in his 30s, and first came to see me back in 2019, a few years ago, and having very obvious, focal impaired awareness seizures, then become focal to bilateral tonic-clonic seizures, and after a few seizures, he was put on levetiracetam by his general practitioner or primary care physician because it's often now felt to be very easy to prescribe, and there was no other red flag for him. But then he kept having seizures. He had another seizure within about 6 months. The dose went up to 1,000 milligrams twice a day. And then he came to see me at that point, and he had another seizure, even with this increased dose. Now, I could have just, let's say, increased the dose further, but there's just something I feel very clear that he's not responding to levetiracetam at all. And he's a young man and is desperate to get his driving license back, get his life back on track. So I decided to change him to a medication with a different mechanism of action, in this case a sodium channel blocker, good old carbamazepine, and he just became seizure-free. And we confirmed, even by doing monitoring at home, we did a 7-day video EEG monitoring at home just to confirm that he did not have any unrecognized seizures, and it's now been more than 4 years, and he's been seizure-free and no side effect.
Yeah, fantastic. And I think we all have similar cases. So with that, we are going to have some closing thoughts. And would you like to give your closing thoughts, Patrick?
I'd like to say that despite all you've just heard from my very eloquent fellow debater, we must start with the position that seizure freedom is achievable for our patients. But in this process, when we're trying different options and treatments, including medications and non-medication surgery and so on, we need to constantly review the goal of treatment with the patients as in partnership, not just imposing our own idea on the patients, because they have many different considerations for every one of them, and they're all unique. And the most important point is never give up, never ever give up.
Yes, I think you're absolutely right, and we agree on that, and we don't disagree on that. But what I think is, when we usually have this view on drug resistance, we count first, second anti-seizure medicine drug resistance, and this is not the point where we should stop thinking. This is where we should start to think and start to act. And it's not a matter of numbers of failed anti-seizure medicines, it's a matter of opportunities. And you put a very nice case, and then even when the failure of the first drug tells you the second drug will not change anything, and there are good data that in focal cortical dysplasia this is the case, early referral to surgery is the best approach. Whereas in others, it's exactly the opposite. When you have levetiracetam and you don't respond, it doesn't do any good that you push it up to the limits. You increase the adverse effects, but don't increase the efficacy so much. So it's a matter of opportunities and not a matter of the absolute numbers. And what I think, comprehensive care is needed in the ideal worlds. If anti-seizure medicines fail, it should be sought after that you look on everything around, including lifestyle measures, including re-evaluation of the diagnosis, focal or generalized, having the right drugs, etc. Comprehensive care is the thing which gives hope.
Fantastic. And I think actually you guys are coming together a little bit, but it's time for our audience to vote. So we want to know, after hearing the sides of Patrick and Eugen, where do you stand now on the question, is seizure freedom always achievable in focal epilepsy? So I would like you to vote now. And I just want to remind people, before we get to that, that the winner should always be the person with epilepsy, which means that you should continue to give that person hope and try the appropriate treatments, refer them, if you have the opportunity to refer them to an epilepsy specialist. If the treatments that you have in your pocket have been exhausted, we would like you to know how to use 3 to 4 or 5 anti-seizure medicines very well and get to be comfortable with them. And don't forget about epilepsy surgery in the most appropriate patients. Most importantly, don't undertreat, but also don't overtreat, because quality of life is extremely important as well. And I think we all believe that the future is very promising. I hope that all of you have enjoyed it and have learned something about treating focal epilepsy, and that will benefit all the people out there with focal epilepsy, many of whom can become seizure-free with good treatment. Thank you very much.
Thank you.
Thank you.